Hi everyone, welcome to my channel. This is Dr. Shilpi here and I'll be covering medical emergencies in dental practice since it's a very vast topic and it's a very important topic for all the fields of dentistry. I'll be covering it in various classes. So the topics that I'll be covering for today are orthostatic hypotension and vasodepressor syncope. So I'll not just be discussing the management part of it, but I'll also be discussing the differences between the two. So let's get started. So the topics that I'll be covering in the subsequent classes are the ones that are mentioned below. So let's start with syncope. So what is syncope? So syncope is an abrupt transient loss of consciousness associated with inability to maintain postural tone. So as the definition says, it's an abrupt loss, so it occurs abruptly. It's a transient loss, so it occurs for a short duration of time. And the patient is unable to maintain your posture. Then why does it occur? So it's usually due to hypoperfusion to the cerebral cortex and the cerebral reticular activating system. So basically there is reduced blood supply to these two parts of the brain. Then coming to predisposing factors. So they are stress, then impaired physical status. So there's a classification of physical status. So patients with PS3 or PS4 or any kind of underlying cardiovascular disease can present with an episode of syncope. Then administration or ingestion of drugs. So in the dental setting, it's mainly the local anesthetics and anxiolytics or sedative hypnotics which are given prior to any dental treatment, which can give rise to an episode of syncope. Then coming to pathophysiology, so this was given by Engel and he described 4 mechanisms to explain the physiology behind syncope. The flowchart below explains the same mechanisms. So now I'll be discussing each in detail. So the first one is reduced cerebral metabolism resulting from inadequate delivery of blood or oxygen to the brain. So the mechanism behind hypotension, orthostatic hypotension and vasodepressor syncope can be explained by the same. Then the second one is reduced cerebral metabolism resulting from general or local metabolic deficiencies, as in the cases where we administer drugs like local anesthetics, sedatives or any kind of acute allergic reaction which can result in a general or a local metabolic deficiency in the body. Then the third one is direct or reflex effects on that part of the CNS that regulates consciousness and equilibrium. Example, in cases of cerebrovascular accident or in convulsive episodes. Then last but not the least, psychic mechanisms affecting levels of consciousness. So there are some psychic mechanisms involved. Example, in cases of emotional disturbances which can either act by their own mechanism or they can act by any of the above 3 mechanisms which were discussed just now, and they can regulate consciousness in the patient. So firstly, we'll be discussing vasodepressor syncope. So it comes under the category of neurally mediated syncope or neurocardiogenic syncope, and it is also known as vasovagal syncope, or it's also known as common faint, and it's usually benign and self-limiting process. So if few things like positioning of the patient or few small alterations are made, then it reverses or limits on its own. Then the normal value of cerebral blood flow is 50 to 55 ml per 100 gram per minute. And for the maintenance of consciousness, we need at least 30 ml of blood per 100 gram of brain tissue per minute. Then coming to the predisposing factors, they have been divided into psychogenic factors like fright, anxiety, emotional stress, then pain, then sight of blood or surgical or any kind of dental instrument, then non-psychogenic factors like upright position or standing, then hunger from dieting or missed meals, then exhaustion, then poor physical condition or hot, humid and crowded environments. So coming to pathophysiology, so what happens in vasovagal syncope? So as we all know that there's reduced blood supply to the brain. So this can be explained by the Vasodepressor reflex, which is nothing but your vagal or parasympathetic hyperactivity. Now what happens in Vasodepressor reflex can be explained by the flowchart on the right side. So there is reduced venous return to the heart. So when there's reduced venous return to the heart, it leads to decreased left ventricular filling in the heart, which in turn leads to increased sympathetic tone in the body, which in turn leads to vigorous ventricular contraction in the underfilled chamber in order to compensate for your reduced left ventricular filling, which in turn leads to increased mechanoreceptor C fiber discharge, and these mechanoreceptors are located in the inferolateral wall of the left ventricle, in the atria and the pulmonary artery. So when there is increased C fiber discharge, it acts on the CNS and in turn it leads to vasodilatation and bradycardia, which in turn leads to the episode of syncope. Then coming to pathophysiology in dental chair. So as we all saw that there's reduced venous return to the heart in these cases. So now what happens and how it happens on the dental chair is what we'll see now. Before understanding or getting into that, first we need to know what are the changes that occur in the human body in general when there's any kind of stress or unexpected pain to the body. So that we'll be explaining through the flowchart. So whenever there's stress, as with fear or sensory triggered, whenever there's unexpected pain, at that time there's increased amounts of catecholamines like epinephrine and norepinephrine in the blood, and therefore there are changes in tissue blood perfusion, and it results in decrease in peripheral vascular resistance and increase in blood flow to many tissues, particularly the peripheral skeletal tissues. So seeing the diagram on the right side, same thing is explained. So whenever there's stress in the normal condition, at that time there is increased amount of blood supply to the peripheral tissues, that is the abdominal tissues and mainly the legs, and also there is vasodilatation, but there's adequate movement or muscular contraction of the legs, due to which the blood is returned to the heart and the cardiac output is therefore maintained, and therefore there is adequate amount of oxygen reaching the brain, and therefore there is no episode of syncope. Now what happens on the dental chair? So on the dental chair, everything stays the same. So whenever there's stress on the dental chair, there is increased amount of blood flow to the peripheral tissues and there is vasodilatation as well. But what is the change now? There is no movement or muscular contraction of the legs, and therefore the blood flow to the heart is reduced, and therefore the cardiac output is not maintained, and therefore there's pooling of blood in the peripheral tissues, and also there's reduced blood supply to the brain, and there's reduced oxygen to the brain. Therefore the episode of syncope occurs. So coming to the signs and symptoms, they have been divided into early symptoms and late symptoms, and the early symptoms include a feeling of warmth in the neck and face, then pale or ashen grey skin color, then cold sweat, feeling bad or faint, feeling of nausea, then blood pressure at or near the baseline level, and heart rate increases significantly, that is from 80 to 120 or more beats per minute. Whereas the late symptoms include pupillary dilation, yawning due to reduced oxygen to the brain, hyperapnea, cold hands and feet, hypotension, bradycardia, visual disturbances, dizziness, and eventually loss of consciousness. So with the loss of consciousness, the breathing may become irregular, jerky, or quiet and shallow, or it may cease entirely and the patient may become apneic. And sometimes muscular twitching of the hands and legs may also be seen. Then the management. So the step 1 is assessment of consciousness and to check for the lack of response to sensory stimulation. Step 2 is activation of the dental office emergency system, and step 3 is placement of the victim into the supine position by slightly elevating the legs, which helps to increase the return of blood from the periphery. And if we fail to do so, if the situation intensifies, it can result in death or permanent neurologic damage secondary to prolonged cerebral ischemia. Then this is the position of the patient where the brain and heart are at the same level, whereas the legs are slightly elevated. Then there's something known as Trendelenburg position. So that is followed by most of the practitioners, but it's suggested that it has to be avoided because the gravity forces the abdominal viscera against the diaphragm in this position. Thereby, it restricts the respiratory movement and it also decreases the effectiveness of breathing. Then this is the position of the patient in pregnancy. So what happens? The right hip is elevated 10 to 12 centimeter by placing a pillow or a blanket below the right hip and by making the patient to tilt by 5 to 15 degree onto the left side, and the pressure on the vena cava is reduced by doing that. If the patient is not relieved even after doing that, then full left lateral position has to be taken. Then anything which is placed below the head of the patient needs to be removed because it can hamper the airway of the patient. Then, as it can be seen on the diagram on the right side, the tongue falls back and it blocks the airway. So step 4 is maintenance of that circulation, airway and breathing and providing the basic life support. So how to maintain it? It can be done by head tilt chin lift procedure. So what do we do in that? We place one hand on the victim's forehead and then we place another hand below the chin of the patient and we try to lift the jaw in such a way that the chin points into the air in line with the earlobes, thereby lifting the mandible and tongue of the pharyngeal wall. Now, one thing that we need to remember is that we should not press deeply into the soft tissue under the chin because this might block the airway, and we should also not close the victim's mouth completely. The second one is the jaw thrust maneuver. So it is done when the head tilt chin doesn't work or a spinal injury is suspected in the patient, and it is done by placing the fingers on either side on the angles of the jaw and by lifting the jaw with both the hands by displacing the jaw forward. And if the lips close, then we need to push the lower lip with our thumb to open the lips. Then the third one is the look, listen and feel technique, where we need to look for the movement of the chest and we need to listen and feel for the feeling of air against our ear. This can be done by placing our ear 1 inch from the nose and mouth of the patient, and we need to look for any kind of airway obstruction. Then we need to also palpate the carotid pulse, and this can be done by passing our fingers in the groove in between the trachea and the muscles on the lateral aspect of the neck, as it can be seen in the diagram, and this should not be done for more than 10 seconds. So spontaneous respiration is usually resumed after doing all this, but sometimes it may cease. So in those cases, we need to give something known as rescue breathing, which is nothing but mouth to mouth respiration or mouth to nose respiration. So in mouth to mouth respiration, a rapid and deeply inhaled breath needs to be taken immediately before blowing it in patient's mouth. It delivers expired air with lowest carbon dioxide content and approximately 16 to 18% of inspired oxygen in it. But the main side effect of this technique is overinflation. Then coming to mouth to nose technique, it is given usually in the cases of fractured mandible or trismus, and it is involved with a smaller risk because of greater resistance to flow of ventilating gases through the nose, which in turn decreases the pressure of gases reaching the pharynx. Then the next step is administration of oxygen. So this can be done via full face mask at the rate of 6 to 10 ml per minute in cases of conscious patients or patients who are unconscious but are breathing normally. It can also be given by a bag valve mask in patients who are apneic and unconscious at the rate of 10 to 15 ml per minute. Then monitoring of vital signs need to be done. Then additional procedures like loosening of ties and belts need to be done. Then use of a respiratory stimulant like aromatic ammonia needs to be done, it acts by irritating the mucous membrane of the upper respiratory tract, and thereby it stimulates the respiratory and vasomotor centers of medulla, and in turn it increases the respiration in BP. Also what it does, it helps in the initiation of movement of arms and legs, which in turn increases the blood flow and in turn increases the BP, especially in patients who have been positioned correctly. So this is aromatic ammonia. It needs to be crushed in between the fingers and then need to be placed in front of the nose of the patient. So this is the back valve mask oxygen delivery device on the left side, and on the right side it shows how it needs to be placed on the patient. Then cold towel may be placed on the forehead of a patient who is warm, whereas blankets can be provided for the one who feels cold or is shivering. Then if bradycardia persists, then atropine can be given, and it's usually given at the dosage of 0.5 mg per ml in 1 ml vial. If it's administered more than 2 mg, then side effects of disorientation or hallucinations can be seen, and it's contraindicated in glaucoma and prostatic hypertrophy cases. Then stimulus which precipitated the episode should be removed from the patient's field of vision. Any kind of terrified dental staff member should also be removed from near the patient, and if there is hypoglycemia, then sugar can be administered, or any kind of orange juice or non-diet soft drink can be given. And if there is delayed recovery, then appropriate medical assistance should be provided and the dental treatment should be postponed. Then to conclude the management in brief, we need to assess the consciousness and check for the lack of response to sensory stimulation. Then activate the office emergency system. After that, we need to position the patient in supine position, and then maintenance of circulation, airway and breathing. Then definitive care, and after that postpone any kind of further dental treatment if there's delayed recovery, and activation of emergency medical services. And after that, we need to determine the precipitating factors in order to avoid any kind of syncopal episode in the next visit of the patient. So the second medical emergency that we'll be discussing today is postural hypotension. So it is also known as orthostatic hypotension, and it's the second leading cause of transient loss of consciousness. And it is defined as a drop in systolic blood pressure of at least 20 mmHg or of diastolic blood pressure of at least 10 mmHg within 3 minutes of standing when compared to sitting or supine position. Then clinical criteria for postural hypotension, that includes symptoms developed when the individual stands, then standing pulse increases by at least 13 beats per minute, then standing systolic blood pressure decreases at least 20 mmHg, and standing diastolic blood pressure decreases at least 10 mmHg. Then what are the predisposing factors for orthostatic hypotension? So these include administration and ingestion of drugs, then prolonged period of recumbency, then inadequate postural reflex, late stage pregnancy, advanced age, then venous defects in the legs, then recovery from sympathectomy for essential hypertension, Addison's disease, then physical exhaustion and starvation, then chronic postural hypotension or postural hypotension. So then coming to pathophysiology. So what happens in orthostatic syncope? So it can be due to transient or chronic volume depletion, or it may occur due to abnormal vasomotor compensatory mechanisms. So coming to the first one, that is transient to chronic volume depletion, which may occur due to any of the predisposing factors like starvation or physical exhaustion, etc. In that case, there's a relative lack of intravascular volume. Therefore, there is reduced blood pressure. The blood pressure falls, and now in order to make up for that, the heart tries to pump more blood by increasing the heart rate, but the blood pressure does not rise significantly. Why? Because there's a relative lack of intravascular volume, because there's an actual loss of intravascular volume. Because of that, no matter how much the heart tries to pump blood by increasing the heart rate, the blood pressure does not rise significantly. Now coming to the second mechanism, which is abnormal vasomotor compensatory mechanism, how it acts is what we will see on the right side flow charts. So what happens in the normal situation when the patient is sitting and he or she changes his posture to the upright position. So at that time we can just follow the flow chart. So whenever there's a change in posture to the upright position, at that time there's an activation of the baroreceptor reflex, and therefore there's an increase in medullary sympathetic outflow. And as a result of that, there's vasoconstriction of the systemic resistance vessels. So resistance vessels are nothing but your arterioles and arteries, and the splanchnic capacitance vessels. So capacitance vessels are nothing but your small and large veins. So there's a vasoconstriction of both of them. As a result of that, there's an increase in peripheral vascular resistance, and when there's an increase in peripheral vascular resistance, there's a significant increase in BP, and that's how there is regulation of blood pressure when the patient stands in normal condition. Whereas what happens in orthostatic syncope? So when any kind of predisposing factors for orthostatic syncope are present, at that time whenever there's change in position to the upright position, there's no activation of the baroreceptor reflex, and there's no increase in medullary sympathetic outflow. Therefore there's no vasoconstriction of the systemic resistance vessels and the splanchnic capacitance vessels, and therefore there's no increase in peripheral vascular resistance, and therefore the BP does not rise significantly, and hence the symptoms of orthostatic syncope occur. Then coming to the signs and symptoms, the prodromal signs and symptoms are rarely noted. So this is in contrast with that of vasodepressor syncope, where we had prodromal signs and symptoms. So these patients may lose consciousness rapidly. They may merely become lightheaded or develop blurred vision, but not actually lose consciousness. Then prevention. So how do we prevent orthostatic syncope? So recording of vital signs should be done. And very important thing, recording of the blood pressure. So it should be recorded, the first reading should be taken when the patient has been in supine position for 2 to 3 minutes, and then a second reading has to be taken when the patient has been standing for 1 minute. And what the blood pressure measurements should be taken in both the arms to detect subclavian stele. This is very, very important, because what happens, what is subclavian stele? I'll just tell you briefly. There is narrowing or occlusion of subclavian artery. So due to that, there is retrograde blood flow to the vertebral arteries, and due to that there is less blood supply to the arms, to one of the arms. So because of that, there can be a difference of blood pressure in both the arms. So therefore blood pressure measurements should be taken in both the arms to detect the subclavian stele. And what happens after recording the blood pressure? The observation is that standing systolic blood pressure is usually within 10 mm Hg. It is higher or lower, but it's usually higher of the supine blood pressure. And the second thing is the heart rate normally accelerates when the individual stands, and it's usually about 5 to 20 beats per minute faster than in the supine position. So then dental therapy considerations. So certain basic precaution need to be taken in certain types of dental patients after taking the medical history. So such types of dental patients are the ones who've had a history of postural hypertension, then patients receiving sedation during dental treatment, then patients who've been reclined in the dental chair for a long period of time. So certain precautions need to be taken during or after positional changes to avoid the episode of orthostatic syncope. So what precautions need to be taken in such patients? So we need to elevate the dental chair very slowly over about 1 minute. We change the position 2 to 3 times before actually reaching the upright position, and we maintain the patient at each incremental level so that we make sure that there's no dizziness felt by the patient at that stage, or it dissipates. Then once the patient stands, at that time the doctor should stand close to the chair to make sure that the patient is able to stand without feeling dizzy. Then coming to the management of orthostatic hypotension, so it's almost the same as that of vasodepressor syncope. So first we need to assess consciousness and look for lack of response to sensory stimulation. Then activate the office emergency system. After that, positioning of the patient in supine position. Then airway, circulation, airway and breathing. And after that, definitive care, which includes administration of oxygen, monitoring of vital signs, and do not panic. And then if the patient recovers consciousness, we need to slowly reposition the chair. But if there's delayed recovery, we need to activate the emergency medical system. After that, we need to continue BLS as needed. And if the patient recovers completely, we need to discharge the patient. Then there are some additional points to be noted, like postural hypotension is only infrequently associated with fear and anxiety, unlike your vasodepressor syncope. Also, there is no vagal hyperactivity seen in the cases of orthostatic syncope, whereas in cases of neurogenic syncope or vasodepressor syncope, we had this venous pooling where there was vagal hyperactivity, which was explained through the Basal-Zarisch reflex. Then in cases of vasodepressor syncope, the patients usually exhibit bradycardia, whereas in cases of postural hypotension, it remains either at the baseline level or the heart rate is somewhat higher. Then there is also something known as Calgary syncope symptom score or Calgary score, which distinguishes vasovagal syncope from other types of syncope. So in this Calgary score, it consists of 7 diagnostic questions which are associated with points, and the total score is calculated by summing the points. So if the score is above the threshold, then the patient is classified as having vasovagal syncope, and if it's below the threshold, the patient is classified as not having vasovagal syncope. Then last but not the least, ammonia should not be given in patients with chronic obstructive pulmonary disease or asthma, or it should be used with caution because it can have irritating effects and it can precipitate bronchospasm. So for the completion of the topic, I have included the following classification, so you can go through them. That brings us to the end of the class. So if you have any doubts or queries, you can leave a message in the comment section below. अगर आपको कोई भी डाउट है या कोई भी टर्मिनोलॉजी समझ नहीं आई है तो आप एक मैसेज छोड़ सकते हैं कमेंट सेक्शन में नीचे. And if you've liked the video, do hit the like button and share it with your friends. And don't forget to subscribe to my channel. And the topics that I'll be covering in my next class are hyperventilation and asthma. So stay tuned for the same, and thank you so much for watching.